Thank you, and thank you for the opportunity to be here again. It's an honor, and so I feel like I need to explain a little bit about the topic because it's the subtitle. It's intentionally somewhat mildly aggressive, not to be confrontational about family medicine versus other specialties, but in the context, the context always matters, right? So if you have a glioma, you need a neuro-oncologist. If you have a broken femur, you need an orthopedic surgeon. If you have a population that's saturated with unmitigated risk factors, you need family doctors. You need them to do their jobs, you need them to do their jobs well. And for any decision makers in the room involved in policy, it's well established in the medical literature that family medicine is, I think it's actually uniquely the specialty where the more you do of it, done well, you actually decrease costs, decrease hospital admissions, decrease mortality. I actually am going to be using a couple slides at the very end that I showed in 2023. So yeah, I'm a family and emergency physician, but this is wearing my family medicine hat here. There's going to be a little bit of geography, just a tiny, tiny little bit. There's some theme here about islands. I'm not quite sure where that comes from, but it's just been my experience. I'll show you with the pointer. So I'm from Vancouver, not Vancouver Island, but I spent the 10 years before moving down here in Newfoundland, and obviously we're here. And at one point later on, I'm going to point out a tiny little island where I did a locum on last year where I think there's some things we can learn from them. So this is my old neck of the woods. This is Burin on the Burin Peninsula. Europe has Italy. This is our boot, the Burin Peninsula. It's the most temperate part of Newfoundland, but as I'll show you, it's not necessarily the most hospitable place. It was very isolated, so 3.5 hours by road to St. John's. That was our tertiary referral center. There were times where we didn't have any internal medicine coverage, and you'd have critical patients, and you'd have to sit on them if we were snowed in, and that happened a fair bit. This is what it would be like. It can snow anywhere from October 1st to June 1st. You can't plant anything in the ground until after June 1st. We would get up to 40 centimeters of snow overnight. That's looking out our dining room at a table. That's not a snow drift, that's just snow that fell from the sky. And the ocean would freeze. Like it's a certain kind of natural beauty that was very nice, and the summers were fun. But it was a challenging environment. Juxtapose that to where we are here. There are some opportunities here that we didn't have there. For exercise there, I had to ride a stationary bike because it's the only thing you could actually reliably do. Because we were isolated, the road would be blocked. We regularly had the search and rescue come. It was nice to be part of an integrated system like that. There was a flight team. They would have advanced practice paramedics that would come with the helicopter. But there were actually more helicopters than flight teams, and the flight teams had duty hour restrictions, so sometimes they'd be able to send a helicopter without the team. So we would have to put a doctor and an RT and an RN together and fly to St. John's. It was pretty fun, and our kids loved whenever it was a clear enough day on the weekend, and we'd park in the parking lot and watch the helicopter come and go. That's my middle son. Other hospitals I've worked in, they all kind of look the same in Canada. It's not about what it looks like on the outside, it's all about the quality of care on the inside. And this is that little community clinic that I mentioned earlier, we'll come back to. So just in case anyone doesn't have the background of what family medicine is, we're well positioned to help manage these risk factors because we treat everyone, all ages, all genders, really most ailments. And it's not that we haven't gone on to specialize. It's not the hill I want to die on, but the fact that we actually do complete post-secondary training in family medicine does differentiate us from people who call themselves GPs who have gotten their MDs and maybe a specialty but fallen back on just general practice. There is a small distinction there. So what I'm going to be talking about is kind of connecting the dots between some of the demographics of the Cayman Islands, the results of the STEP survey, some of the conditions that ultimately cause morbidity and mortality, and again, some evidence for having continuity of care in family medicine, how that can save money and improve outcomes. This is just an oversimplification. What do we want? We want long, healthy lives. How? By preventing disease, detecting disease early, reversing diseases when we can, and manage them when they get chronic, if they become chronic. But I'm really going to focus just on preventing disease, because that's where we are uniquely situated as family physicians. So this is the population pyramid. I got this from Dr. Gent. I don't know what year exactly this is for, but it's kind of alarming if you're used to looking at these, because it's very young. Now, it is a superimposed situation where you have the Caymanians and expats, but as the STEP survey looked at all residents and showed that there's a lot of unmitigated risk factors in the population, the way I look at this, I use the term a tsunami of pathology that's coming, and I still stand by that, because young people with risk factors turn into old people with diseases. So really the time is now to do the prevention work. These are the top 10 leading causes of death. May as well look at it, because this is what we're up against. This is what we deal with. 70% of all Americans in 2023 died from one of these things. So look around, it's not going to change. These are the things. I've been reassured that the statistics are similar in the Cayman Islands. There's not much difference. It did cross my mind as I've been here today that there was another theme that came up, and I was just, obviously this was in 2023, so COVID was still on the list, but I just wonder if anyone knows what was displaced by COVID? Just think for a second. It was actually suicide, and mental health. I see some people nodding here. Mental health is definitely a key part of family medicine, and probably if you looked at the aggregate amount of work that we do, probably most family health is delivered by family doctors. We're not the specialists in it. The psychiatrists will deal with the more complex cases, but it would be weird to talk about family medicine for an hour without at least mentioning it that much. So what I'm doing now, going forward, is I'm taking that rank-ordered list of causes of mortality, and I've put them all there. And we want to work backwards, because in family medicine we want to decrease everything that leads to that point. So ultimately, in my mind, there's behaviors that result in risk factors that result in disease. So these are the risk factors, and if you look at all the evidence, sometimes it's hard to remember which causes what, and it's not intentionally complex, but it obviously is. The main thing is all of these things cause all of these things. So what we want to do, and what I'm going to do from here on, is use this as a framework to talk about each of those risk factors and what we can do as family doctors to help move the needle. So there's not enough time to go through all of them very thoroughly, but there's some key things that I do in my practice that I think makes a difference in order to prevent ending up with all the chronic conditions. So hypertension. And I didn't quite mention it yet, but one of the things that I think helps is education. So, and this highlights it well. We've really moved the goalposts with respect to controlling blood pressure. We keep on changing what the target blood pressure is, and I think we owe it to our patients to explain why. It seems like we're almost just kind of being mean by saying, okay, it's not 140 over 90 anymore, now it's 130 over 85, or now it's 120 over 80. I think they deserve to know exactly why, and it's because we've got really good data. So this is 61 prospective studies over 1 million individuals, just showing that there is this logarithmic relationship between elevated blood pressure and risk of several things, starting with stroke. So if you just look at those couple data points there, someone in their 50s with a systolic blood pressure of 115 will give them an arbitrary risk of having a stroke of 1. And if you were to compare them with someone in their 50s as well with a systolic blood pressure of 140, their risk of having a stroke goes up 3 times. And this relationship holds for every decade of life and carries across for ischemic heart disease and mortality from other vascular mortality like rupturing aneurysms. So I think when you show patients this, it can make sense to them that their blood pressure of 138 over 90, while they might not feel anything, it is a silent killer, and lower is better, and there is no floor effect. You can the lower your blood pressure is, the better the more you're reducing your risk of these conditions. And every little bit of salt you eat and every time you don't exercise, it all ends up mattering. There's a lot of data in the STEP survey. I kind of distilled it down to this one fact here that I think is the most kind of translational or easy to understand. The 22% of the population having uncontrolled hypertension. Those are all adults from 18 to 69. That's 1 in 5. That's huge. And that's using a cutoff of 140 over 90. So those are people who already have a 3 times the baseline risk of having a stroke. That's not using the more modern, lower cutoffs. So if you want to, and I've had this slide deck on my computer for the last month, and so now I'm showing my patients this, and I think it's great. It does kind of open their eyes. So when you can actually lay it out for them like this, sometimes it just is that one extra little piece of motivation they need. If you find someone with high blood pressure, this is just my practice. I'm sure it's done very similarly in others. I give them a blood pressure log. I get it started for them. I tell them they have to check their blood pressure morning, afternoon, and evening. The point being, you want to catch the dippers, non-dippers, reverse dippers. So most people are dippers, their blood pressure is lowest in the morning. But if you're only checking in the morning, you'll miss out on finding out if it goes up later. And you can treat the non-dippers differently, usually with like a calcium channel blocker at night. First line treatment is not medication. It's 150 minutes of vigorous exercise every week and avoid salty foods, processed foods, look at the labels of your food, and come back with your blood pressure log. Very similar with dyslipidemia. There is a dose response effect. Here it's showing that the more you can reduce someone's LDL, the more you reduce their vascular events, so heart attacks and strokes. Again, with cholesterol, there is no floor effect. So the lower you lower someone's cholesterol, the better. Even extremely low LDL is best. So while this might be hard to show somebody that doesn't have experience looking at statistical graphs and studies, the cholesterol trialist treatment collaboration came up with this relatively straightforward graph. I find a lot of the time I'm combating what people are learning on social media, which is kind of frustrating. It's like their biggest motivation is to get off their statin. But I come back to this and say, well, my motivation is for you to live a full, healthy life. You can go off your statin, but you should understand the risks. Just dyslipidemia is very prevalent in the Cayman Islands. The percentage is about 1/3 of the population, both genders. Another graph or figure we're showing people in person, and the wording I use to kind of communicate what it's like is, imagine you're just breathing through a straw. You can do it, but it's not very comfortable, and if you were to try to exercise or you got sick, you could die. So I think the visuals, they're not nice to look at, but you show a patient that there's a small incremental chance that you will get them to go along with your treatment plan. Just highlighting the downstream effects there. Moving on to smoking. Smoking is actually, there's been a lot of success here. I'm obviously not going through the pathways of the pathophysiology of smoking, but there's interplay with everything. So, it affects the quality of your lipids and how they can no longer bind receptors and how they turn into plaques. This is stuff we know. But the risks of cancers, it's helpful to tell patients about all of them. And but it's one of the few things which is actually improving. So this is very similar. I think it's 12.5% of people smoke here. It's basically the same in the United States, and the rates are trending right down. The incidence of e-cigarettes or vaping is on the rise. This is a concern. Patients ask me about it a lot, and I tell them that it has one role, and that's as a stepping stone for people who are quitting smoking, and that is it. I have had patients successfully transition to vaping and then transition off, and so now they're non-smokers, and that was their form of nicotine replacement therapy, just like you would use a gum or patch, a lozenge. But the phenomenon of people just starting vaping that's a whole other public health issue that I feel kind of powerless against. You pick and choose the statistics that you tell your patients. So if they're under 40, tell them that those who quit by 40 have a life expectancy similar to people who have never smoked. If they are over 40, tell them that after being quit for 10 years, your chance of dying from any smoking-related complication gets cut in half. After 15 years, it goes back to as if they never smoked before. And it's not listed here, but I often tell patients that on average, it's the 5th time someone tries to quit that they stay quit for life. Sometimes it's the first time, and it's after the birth of a child or grandchild or heart attack, but sometimes it's the 10th time, so just always try again. And this basically just says that we should all be familiar with the smoking cessation treatments, nicotine replacement, and then also the medications, Champix and Zyban. Their numbers needed to treat are 8 and 14. They're not great, but they're better than nothing, and every incremental attempt at quitting is worth it. This basically just says that we can't. It's disingenuous to tell patients that e-cigarettes are as bad as tobacco. It's just not true. And we don't have enough data, but we don't have data that shows that it causes the cardiovascular disease that smoking does. So I just go back to saying you can use it to get off of cigarettes, but never start because we just don't know how bad it is. These are the 5 A's, trying to establish how ready someone is to quit. I just like to highlight the 3rd one there, assess. Like it's almost too easy to ask if somebody smokes, and then they say they do, and then you tell them they should quit, and it just kind of goes in one ear out the other. But you got to ask them a question that kind of has to echo in their brain a little bit. So ask them, when do you think you'll be ready to quit? Or have you thought about quitting recently? It's a little bit harder for them to dismiss it, and it's a better chance it'll stick. Smoking causes 7 of the 9 top causes of death, or is a risk factor, I should say. Obesity, very prevalent, multiple mechanisms of disease. Interestingly, about 4 to 8% of all cancers are attributable to obesity. And this is where we get into a really fun distinction. So I'm not sure, we're doing the hand thing today. How many people have heard of the obesity paradox, which is highlighted here on the graph on the left, which is actually that when you look at large populations, obese people actually tend to outlive the rest of us when you're using a BMI-based definition. So BMI is horribly flawed, and I'll go into some more anthropometric data later, but there's other ways to look at it. The NHS really likes waist-to-height ratio, and that's my new favorite too. So in all my patients, I measure their height, I measure their waist circumference, and we graph it. So as you can see on the graph on the right, the all-cause mortality increases quite sharply when the waist-to-height ratio is above 0.61. So this is the log of the hazard ratio of mortality, whereas when you're looking at just BMI, it actually shows a survival benefit, which is funny, but you can imagine in the extreme cases of like bodybuilders, they're actually quite fit but have high BMIs. But applied to other mortality, cardiovascular mortality, other cause mortality, the waist-to-height ratio is a really good discriminating measurement. It's very easy to measure, and we'll get into that again in a little bit. The cancer mortality is not quite significant in a small, like I said before, obesity being attributable to or causing 4 to 8% of cancers. It's a very small effect, and you can kind of see that there with the p-value of 9 and a sample of only about 500 people. But using the BMI-based definitions, a third of the Canadian population, or the resident population of the Cayman Islands, is obese. And under interventions, we'll be talking about that under the next couple sections, physical inactivity. So the relationship between physical inactivity and development of dementia and cognitive disorders is becoming very clear. This was a really cool study from just earlier this year. So what they did is they had 50,000 people in the UK, and they watched them for 12 years, but at the beginning everyone took a genetic test, and it looked like this panel of alleles that's associated with developing dementia. So people were put into 3 different groups, but then they stratified it later as having either a moderate or high risk of developing dementia or a low risk of developing dementia. And then they looked at their cardiorespiratory fitness. And they did this in a really good way that was able to include everyone. So sometimes when you're looking at fitness, you get people to go to maximal exertion, and if you have any disability or you're deconditioned, you just can't complete the test and the data gets thrown out. But they were able to use a sub-maximal exertion model, and they found that among that baseline, the people who had high cardiorespiratory fitness basically decreased their risk of developing dementia over the next 12 years by a third. So that's this compared to that. And the relationship held even if they were, if they're at a low risk of developing dementia as well. So this is a third lower than that. So regardless of your genetic predisposition to dementia, if you have high cardiorespiratory fitness, you can decrease your risk of developing dementia by a third. So that is very well established now. The lack of physical activity is obviously very concerning. 72% of women not engaged in vigorous physical activity in the Cayman Islands, and a third of men. So this is where we go back to that other island. So I was the only physician on this island for a week, 24/7 coverage. We were in the clinic in the day and had a walkie-talkie and a pager at night. And it is, we're going to be moving over here. So just for reference, that's Vancouver Island is this, and it is 12,000 square miles. Grand Cayman is 76 square miles, and Hornby is 11.5 square miles. But it has 50 miles of hiking trails. It's a beautiful place. It's kind of like misty. People use the trails for recreation, for socialization, for getting around the island. And I think the take home here is, Cayman does not look like Newfoundland. And there is, the opportunity to develop, hiking and outdoor recreational activities. A trail system like this, I spoke with Dr. Jend about it, and he said there is zero chance that's going to happen in Cayman, David. So I think you guys should do it just to spite him. But what I want to highlight is on this trail map, it's a cooperation. So there's Crown lands, there's a provincial park, this is a regional park, and these are private lands. So I think as a community, the place is much better when everyone plays a part. As I showed you in those pictures before, the trails are pristine, everyone takes care of them, they know that probably anyone could ruin this for everybody, but as it is, it's an amazing place, and it seems to be working. So I don't think that, I think if there's a will, there's a way. A bit of a hard transition here, but in clinic, I take an inventory of people's many different measurements, but one of the things I've started doing in the last couple of years is calculating at each visit. It's a snapshot of something called a FIT score. It's an acronym for frequency, intensity, and time. So we ask for the 3 activities they do the most, and for how long they do them, and how often. So this is actually a patient, and he's an internationally competitive triathlete. And we'll see, his measurements after, but you can see here that he's, cycling, rowing, and swimming at, competitive amounts pretty much every day. He's doing one of them. So that FIT score of his is 165. It's kind of off the chart here. But it's really nice when people don't have much to say in that inventory, and they end up in the sedentary range or only lightly active range. It just kind of puts it up on a big screen, and we can tell them, look, this is the input. And if you're having some outcomes that you don't like, it's not a terrible surprise because you're not doing the work. So this individual's other measurements show his waist to height ratio is in the green there at 0.46. His BMI is in the healthy range, and his percent body fat, I like this, it puts it within the reference range for his demographic, so it's men in their 50s. He's right in the middle of the green zone there. The other thing I measure is grip strength, and he's above the 90th percentile for his age on dominant and non-dominant hand. This is another patient. We'll call him the bodybuilder. He does the weightlifting and rope jumping exclusively. And you can see this reflected in his data. So he's also very active. His waist to height ratio is perfect, but technically he's obese. Now he's extremely fit, and he's the responsible, the reason that there is this obesity paradox and why BMI is not terribly useful. I think it irked him that I showed him that his grip strength was not above the 90th percentile. He's very competitive, but that's what happens when you use machines, not free weights. But the grip strength itself is not something to optimize. It's a proxy for your fitness, and I'll actually mention that a little bit later. This is another patient, and he plays basketball and walks, but he knows he could be doing more. His fit score is in the green, but his waist to height ratio is high, his BMI is high, and his percent body fat is elevated. So these are all kind of concordant things that show that his BMI being 30.9 is actually pretty accurate, that he is obese. And his grip strength is just above the 50th percentiles. And this is another patient who only walks, and so it comes up pretty clearly that she needs to do a little bit more activity. And her waist height ratio is elevated, BMI is elevated, percent body fat's elevated. So it's pretty clear that some more exercise is needed there too. So why look at grip strength? Well, it's kind of exploded as this super easy to measure thing that is a proxy for your fitness and correlates with all of these outcomes. So I know you can read them there as easily as I can relay them, but it's worth checking, and the main thing isn't to optimize it, it's to check it, and if it's low, then it's an easy way to kind of transition into an inquiry about their physical activity and how you can improve it. This is a handout I made a couple years ago. I've given out hundreds of them, I'm sure. I've given probably multiple copies to the same patient when they come back with the same problem, and we go through the same thing, and they're not doing anything, and they don't know where to start. So these are all things that I've put together that I think they serve two purposes. So they're good, easy, accessible ways to start exercising. You don't need anything other than a yoga mat and a couple free weights. But they also serve double duty for preventing certain medical problems. So the crunches and planks can help build your abdominal wall strength and prevent abdominal wall hernias, which, as we know, are one of the most common things people need surgery for. The shoulder presses help with the internally rotated shoulders that we have when we're sitting at desks all day, and the lateral raises strengthen your supraspinatus, the most commonly torn rotator cuff muscle. So unhealthy diet, very hard to do this justice really quickly, but it's quite in your face here. Literally, as I was thinking about what to put here, I was having lunch with my son, and I hate to say, but we sometimes bribe them with a quote special drink if they kind of there's three boys, if they can kind of behave themselves. So they'll say, okay, if you can keep it together, then you can have a special drink at lunch. The nutrition label on this is kind of alarming. First, I didn't realize it was actually an energy drink, although I guess it does say it there. 48 grams of caffeine. I don't think he's a 13-year-old. I don't think he needs that. But I remember growing up when Coca-Cola was considered like the highest sugar drink you could get, with like 30-something grams of sugar in a 355 ml can. I can't quite see here, but I think it's 63 grams of sugar in 360 ml bottle. That's insane. It's the chemist in me, I did biochem, it's kind of hard to believe you can actually dissolve that much sugar in 360 mils of water. I don't think anyone would ever actually need to drink that, maybe if you were like halfway through a marathon, but just a 13-year-old sitting around at lunch, it's not good. So this is from the STEPS survey. This is just about how often people are eating processed foods high in salt. Always or often came in at 25%. That's for the 18 to 44-year-olds, and then all comers was 19.4%. I'm sure there's a huge amount of overlap between that 19.4% and the 22% of 18 to 69-year-olds who have uncontrolled hypertension. They must be the same people, in my mind. Recommendations for what to do here, I don't think I can say it better than what's in the STEP survey. where there should be front of package food labeling, there should be a local food guide. In Canada, we have a Canada food guide, but you should not bring something like that here. It should be locally developed with the local foods and what you can produce locally. It can be a source of national pride. We should do that, and having nutritious food, setting examples in the schools is also really important. Excessive alcohol is I'd call it an endemic problem in Cayman. The amount of drinking here is just hard to believe. The US Surgeon General popularized the relationship between alcohol consumption and cancer, saying that it's responsible for about 12% of cases. And the statistic that kind of translates well to a clinic conversation is that alcohol-related cancer deaths annually is actually more than all motor vehicle accidents annually in the United States. So 55% of residents are current drinkers, and the statistic that it's like there's a disconnect, because I'll show this to my patients and they'll say, "Oh, I thought it would be more." But to me, it's like, I can't believe that, really? Like, you see what this is? This is like binge drinking. So 25% of all comers drink 6 or more drinks in the last month. So like 6 or more drinks on one occasion. That is excessive, I think, by any standard. I don't know what the marginal benefit you're getting from that 6th drink is. It's probably not worth it. And you know, the costs, if they're kind of laid bare, if you show them the graphs, are, for the example here, the cancers. So oral cavity and pharyngeal cancers, esophageal cancers. The x-axis here is grams per day. 42 grams is basically 1 drink. So you're pretty much doubling your risk of these types of cancers over the baseline. And there is a statistically significant association with the other cancers here, just a little bit less. I think that these safe drinking guidelines, they just fall on deaf ears. This isn't the thing that I think really moves the needle with your patients if you tell them, you know, not to have more than a couple drinks on a day, or how many in a week. I think that goes out the window. Or if you tell them, you know, not more than 15 standard drinks per week, they'll probably think, oh, I can have that in one day. So it doesn't get anywhere. But the NHS does have this suggestion, which I've tested it on some patients, and it seems to resonate. This concept of only wining and dining. So if you are going to drink, like if you're going to a restaurant, don't have your first drink until your food is served. You will probably cut down by a drink or two. It'll slow you down and it'll delay the start. So I think that's a way to just make some, you know, marginal progress. So altogether, this is an issue that's going to be, you know, very hard to address through family medicine, but deserves to be mentioned because it comes out in the data a lot, is the effect of socioeconomic status being a multiplier of all of the risk factors. And that is, it comes up in the data as well. So when you look at low socioeconomic status and its effect on mortality, it's actually worse than hypertension or obesity. You can speculate about all the reasons for it, but probably the pattern of underutilizing primary care or healthcare in general and only seeking reactive utilization is the main problem. The SHIC survey, the STEP survey highlighted that only about 20% or 1 in 5 are on a Cineco plan, and 5% have no insurance, 17% have a SHIC plan. The pattern I've seen with patients who are underinsured is that they will try to utilize it 0 for the whole year in case something comes up, because they don't want to run the risk of having to pay out of pocket for anything. And then the savvy consumers will, in the last month, use those benefits to get some preventative care done. But we shouldn't really have to get people to game the system like that during December to try to get some fasting blood work done or things that will ultimately help them. A simple way to possibly improve on the current situation, I would humbly suggest maybe let people's unused benefits roll over into some sort of account that then proactively is used to recall them to get their missing screening done. Just on the margins, that would make a difference, because otherwise you have a lot of people that, you know, I'm sure it's frustrating to all the other specialists here too. Like, you'll have somebody that's a surgical candidate, and then you find out that their A1C is 12. Like, this stuff should be caught much earlier, because these are silent killers that are going undetected. Back to the thing I mentioned at the beginning, just how this can actually save money and improve outcomes. This is a study, I think this is the one out of Norway. I mentioned this, I showed the same graph in 2023, that it really elegantly shows that the longer a patient has been associated or affiliated with a family physician, the decrease there is in their utilization of out-of-hours services, so that would be like an urgent care or emergency department, the decrease their rate of hospital admissions, and there actually decreases in mortality. So the longer you're associated with a single physician, the better the outcomes. You can speculate about the mechanism of that, but I think it's pretty obvious. Once you have somebody who knows your history and knows your family's history and sees you changing over time and make sure that your screening is up to date and can just kind of hold your hand through your health experience, the more likely you're going to get the right tests at the right time, that your screening is going to be up to date, you'll get the right interventions, there won't be redundant testing, there won't be wasted opportunities to make sure that someone's care is optimal. There's been a lot of other studies that back this up. So as continuity of care with the primary care provider increases, ED visits decrease, hospital admissions decrease, hospital readmissions decrease, all-cause mortality decreases, and healthcare costs decrease. It's just some simple suggestions, I'm sorry about the small font, of how this could be promoted really easily. Make sure that whenever a patient sees a specialist, they actually document who the patient's family doctor is and CC them on all reports. This is not done. It seems to be a perennial problem. It comes up at pretty much every meeting I go to. Still not done. Hospitals, labs, and imaging facilities, same thing. CC them on all reports. This is common in other places, just not in the Cayman Islands. Policymakers brainstorm and come up with a way to facilitate patient attachment. Otherwise, you're going to end up spending a lot more on patients' care when they're going to the ERs and having end-stage disease. You should get these people hooked up to family doctors that are actually doing evidence-based care. And that's all I got. Do you want to go ahead with your question?
Yeah, according to the new guidelines, the elevated blood pressure is now considered, the systolic number is 124, if I remember correctly. It was between 120, so it's starting from 120 and above, yeah, here.
Yeah,
elevated.
Yeah. So the benefits in lowering your blood pressure go all the way down to 115 systolic, and we don't know below that, but they go down at least to 115. But yeah, what you want is less than 120 on the top and less than 80 on the bottom.
So I personally think it's artificially lowered. Do you really think that a patient who comes to you and he's like 70 years old with a systolic blood pressure of like 125, do you consider it as elevated, and what do you do?
So you need to individualize it. That's a great question. So it depends. Is this a 70-year-old who's fallen a few times? Well, then you don't touch it. Is it someone who is middle-aged but doesn't exercise and eats poorly? Well, then you use it as an opportunity to start that conversation of, I wonder what your average is like. This is actually worse than if it was 114. And so we know that. Now, it's kind of, so you want to, in general, help the patient identify what is the thing that will, on the margin, help their health the most. So there's going to be diminishing returns at optimizing someone's blood pressure below 124. Like there's probably other things that they could be doing. But if it's the way to start the conversation, like do you start medication on that for that patient? No, that would be very hard to defend. But you can use it as a way to get them to think critically about their sodium content of the food or whether they're actually exercising as much as they could. Because if you can move the needle there with the exercise, like we're not just treating this number, we're decreasing their risk of developing dementia, cardiovascular disease, everything else. So yeah, I think you do tell them that it would be better if it was lower because that's just the science. But you want to encourage them to do that in a way that's going to benefit them. Because there is also cost to medication and there's risks to over-medication. So does that answer the question?
It does, but I just think that like the systolic blood pressure of like between 120 and 130 used to be normal.
Yeah.
And for some reason now it's just like going down and down, and next year will be like 110 is elevated.
Yes, this highlights the most important point here is that the education is so important. You know, if you have a patient who's obese and their blood pressure is high, like it's not good enough to just tell them to eat better and exercise. Like that's a failure, I think, of a family doctor. Like what you really need to do is show them figures like this and explain. Like they deserve it. Like and these, you know, your patients deserve that, the benefit of us believing that they can understand some very clear examples if we hold their hand and show them why. Because some of these people are, you know, they're everyone. They're experts in their own other fields, and it could be a data scientist who totally gets it really quickly, or it could be a teacher who hasn't seen a graph like that, but then you show them, and it's just like asking that question about quitting smoking. Like if you just get them to think about it a little bit more and make it make sense to them, you're building a network in their brain that then they're going to ruminate on it, and they might think twice about, you know, that salty bag of chips they have every, you know, couple times a week. So yeah, the education is the key thing.
Thank you.
No problem.
And at this stage, I'd like to say thank you very much to Dr. Kwinter for a very engaging presentation.
Thanks.